I think all four speakers provided great insight into various aspects of what this style of this seminar was, which is dosing software in clinical practice. And I think some of the questions that have come about, there've been a couple that I might actually ask the first one. I think another one that Sebastian might have received. But it's one that was early on, and it's a question from Michael Legg. And the question is the vancomycin aim goal 400 to 600 applicable for general ward patients as well as the ITU or IC, or presumably should we vary the aim based on how sick, target, I suppose, based on how sick the patient is or where the infection is? So I think I might get somebody who's actually live here with us, Amy, to have a look at that aspect of those two questions. Thank you.
Okay, great. Well, I'll start off and then feel free to jump in, guys. But so the target of an AUC to MIC ratio of 400 to 600 is applicable for all patients on vancomycin, specifically those with MRSA bacteremia. I don't know how much we want to get into this. What we tend to do is assume an MIC of 1. So most of us aren't actually doing an AUC to MIC ratio. The majority of people are actually just calculating an absolute AUC and targeting 400 to 600. And then assuming that the MIC of our pathogens are 1. There's actually slightly lower targets for some of the non-MRSA gram-positive. So there's a slightly lower target for Enterococcus and some Streptococcus, where the AUC targets are somewhere between 350 and 370. But realistically, around 400 as an efficacy minimum is very reasonable. And the upper limit of 600 really has nothing to do with the MIC at all. That's related to an unacceptable risk of nephrotoxicity. And nephrotoxicity doesn't care about the bug. Go slong so that's where the point of 600 is applicable to ward patients and ITU. Should we vary the aim based on how sick the patient is? Probably not. What we shouldn't do, as Tony so eloquently said, is assume that a trough of 20 is better than a trough of 12 because the patient's in ICU. And that is traditionally how we have probably encouraged people to think more is better. But that's really out the window now, and it's really about an AUC to MIC ratio of 400, except I'm also telling you to forget the MIC, and you need to have an agreement with your lab, but if they're starting to see MICs creeping up above 1 using an appropriate method, that they need to let you know, because it's very hard to achieve a safe target if your MICs from an appropriate method are 1.5 or 2. Now, where the infection is a very good question. In Australia, we aim for 20 to 25 as a trough for CNS infections. And there's no real evidence to guide our dosing in that space unless we're doing CSF concentrations of vancomycin. So CNS infections is the one thing that's a little bit of a grey area. I don't know if all of us online even necessarily do the same thing, but for now we have maintained a slightly higher trough concentration at my hospital for CNS infections, rightly or wrongly, with very close monitoring of renal function. And often, even though we used to think, and again, Tony's all over this, but we used to think that having a nice big peak really forced the drug into the CNS, but actually you can achieve really good CNS concentrations with continuous infusions, which are a bit safer when you're also aiming for those higher levels. And that concludes my talk on the first question.
Thanks, Amy. We've got 3 other experts online. So any comments from Tony, Sebastian, Paul? Feel free to add any comments or insights you'd like to impart for the audience.
I think the question was very well answered. Just for the CNS, some centers and also our center is using intrathecal administration for vancomycin to get the levels very high in the CNS. That could be another option. And then I think Amy nicely answered that. AUC MIC is the best we have at the moment, but I would love to see more target site specific breakpoints, but we don't have the data to make good recommendations in that direction.
Tony, did you want to say anything, or you're pretty cruisy there? So no comment at all.
Yeah, I think Amy's done a really good job here. She's probably much better than me. But I'd probably like to touch on how the threshold, the 600. You can find the confirmational biases somewhere. When you look at some pages, they will quote 700, but it's not like you immediately flip over to AKI. I just want to really articulate that it's a spectrum of risk, all the way up to 800 and 1,000. So the more high you go, the higher risk of AKI. It's not just, you've gone over that threshold, there's an immediate odds ratio that it flips over. So this kind of ties in well when we give VANC with quite higher MICs above 1 or 1.5 or 2. It's just how willing are you going to accept that risk of AKI to achieve that target PK/PD, because the MIC is the denominator. Yeah, that's all I had to add.
There is a nice follow-up question from an anonymous person asking about the AUC targeting and ophthalmitis. Any comments from people who might have been using? Question is, would a target be closest to 600? Was that what you would be targeting in cases and ophthalmitis?
I admittedly don't know. I would need to look at how good the penetration is to that site of action. I do believe the Sydney Eye Hospital does have local administration into that area, like a formulation to make up for it. So I would presume the higher the better. But in saying that, I have not treated an MRSA endo-ophthalmitis in my experience.
We might move on from VANC. I know it's very topical that people love talking about it, and we can talk about it for the next 20 minutes. But I think we might go on to some other questions that are quite relevant. I think this one should be pointed to Paul, given the fact that he's recently published a paper in Critical Care looking at the enablers and barriers for different TDM type strategies in ICU. And the question is, what have been some of the barriers to implementing dosing software in practice? And I think Paul might be well placed given his study that he's published.
Yeah, okay. Thanks, Oz. So barriers to dosing software, or TDM, which I think I've touched on some already, but obviously turnaround time, assay access, I guess there's geographical barriers or equity of access throughout globally as well being a barrier. I think one of the biggest barriers I find is actually institutional or buy-in from clinicians, or the variation of clinicians, or they either are pro or they're. I find it's quite often that people have strong views on this topic, which I think is actually a barrier as well. It seems to be sometimes tough to have discussions around this where there are very strong opinions about TDM and should it be used or shouldn't it be used. So I consider that a barrier as well. Also, I think just the interpretation of TDM and what you're targeting and what the goal is, or the time above MIC, or the AUC target, or what the MIC is, or do you use clinical breakpoints? There's lots of little kind of niche discussions that happen, I think, that are barriers to implementing the service. And I think, as I touched on before, just in terms of dosing software, its usability, its frequency of changing, those sort of things with some software is a bit of a barrier to implementation, and having the people with the expertise to implement it. Probably
I think only 3% of respondents from memory, only 3% of the respondents were using dosing software. Is that right, Paul?
Sorry, that was hard. So respondent, yeah. So dosing software use in practice, I think it was depending on the agent, but maybe it was 10-12%, I believe.
Yeah. For beta lactase, particularly, I think for the new ones, but maybe that's what I was, and I'm very surprised at the number.
There was huge variability in areas, and especially on, I guess, the income status of countries. Obviously, more in high-income countries than others, but fairly low uptake at this point.
All right. Next question I might move on to is, what are some of the speakers' thoughts regarding TDM unbound versus solo beta lactase? I know that definitely here at the Royal Brisbane, we went to move over from solo to unbound. I can give my verdict on that, but maybe I'll ask others on the implications of this on using different dosing software programs. AD, maybe you might want to have a comment, given the fact that you do a lot of TDM.
I can be quite quick. So we get unbound levels, and I use unbound levels in, again, I'm primarily using IDODS, which also you can just choose unbound. And I know the only thing that have come up recently is, so for most of the drugs that are obviously the efficacy targets are based on unbound concentrations, and, we're very grateful to have those. The only drug that recently has been a bit difficult is a lot of the data about toxicity related to ceftriaxone is linked to total concentrations. And so we often have these very low looking ceftriaxone concentrations, and we don't know what our total concentrations are. And so sometimes that's just a bit hard to explain to people that actually your total concentrations quite a bit higher. But yeah.
Any other comments from others, Sebastian? Paul, any comments?
A good idea. Very nice that you can do unbound concentrations in practice. In Germany, that's not very common, but certainly closer to reality. So if you can do it, I think it's great.
Look, in the interest of time, because we've only about a few more minutes and there's a few more questions here, a couple that are coming your way, Sebastian. And one of them is, any plans to implement the PK model for linezolid into TDMX?
Yeah, thank you. That's a good question, and we're working on that. So as we speak, we're doing some of these evaluations I've showed you for vancomycin with linezolid, and there will be a model out maybe in early 2024. So we're working on that. I agree. Linezolid is an interesting drug to study as well, and to come up with solutions to better dose it. Yeah.
And another question from Sherilyn, which is, what was the rationale for the models that are available to selection in TDMX?
Yeah, I think there are two aspects. Some models are itself quite good models, such as the GOTI model. That's one of the models I highlighted for vancomycin. Those are implemented. And then also more specific models are also implemented that are really different from each other. But those are the models that performed very well when you use them together in these averaging or selection algorithms. So if you use TDMX and you enter data, I would start with a general ward model, such as GOTI, for instance, or if you have an ICU patient with a specific ICU model also. But then always try to check which model fits your individual patient best. You can do that manually by just clicking on the models, but you can also use the auto-select, for example, to see, okay, this might be a model that might be best for my individual patient. So yeah, we gave this some thought.
Hey, I might move on just to the last question, because that's quite good for people who are thinking about how they can be, I suppose, leaders in their different settings where they work. Are there any sites that allow ICU or IV pharmacist-initiated TDM? I know that from a background at the Royal Brisbane, we've had a lot of collaboration between the pharmacist and the critical care clinician in initiating a lot of this. But I probably want to give them experiences from other people. Tony, I know that you work in a very niche area in the pediatric space, and obviously AMS covers the whole gamut of general wards and IC. What's your take on being able to initiate TDM in that capacity?
So I guess two things. We can't order levels, but we have tabled that at a drug committee level for certain pharmacists like myself, my IC pharmacists who are equipped and have the expertise to interpret the levels and recommend doses. Because I think what at the governance or what they're scared about is a pharmacist who goes off the rails and orders bloods on and levels on a patient who doesn't need it, and especially
as opposed to a physician who does that.
Sorry,
as opposed to a physician who does that, I suppose.
Sorry, I missed that.
That's all good. I was just being facetious. That's all right. You carry on.
Oh, okay. Yeah, but at the moment we don't, but we have tabled it because the doctors tend to listen to whatever we suggest now. We've come to that level of rapport and respect in our TDM service that we say, oh, can you take these levels? And the nurse takes it for us, actually, because the limitation of a pharmacist being able to order levels, we can order it through our EMR power chart, but that you still need someone to accept that order and go to the patient and take the blood. And most often that would be left over to the phlebotomist either the next day or you missed the 10 a.m. run. And arguably, if you're not using Bayesian forecasting, it could be an inappropriate level outside of the trough level or the peak level you're looking for. But I guess the beauty of Bayesian forecasting, you can use any level. But at the moment, we are trying to overcome that challenge, certainly at a drug committee governance level, to allow pharmacists the ability to do that, but taking note that there are reservations, and we want to limit that ability to certain pharmacists. Yeah.
Excellent. Look, we've got about 3 minutes left. I might just ask one question because I'm curious to hear about what people might think about this. We've heard about the Dolphin study, which Paul outlined. Sebastian, you also talked about use of clinical trials to evaluate dosing software. We know of the Dolphin study that there was a delay of about 36 hours for the intervention, i.e. the suite of TDM dosing software. There was also criticism of the model that we used in one of the beta-lactams, because it was beta-lactam and Cipro. It was beta-lactam, it was ceftriaxone, and the model might not be perfect because of the fact that it used total concentrations. My question to Sebastian and Paul, really quickly, is what should an ideal clinical trial to test the utility of dosing software look like in your eyes, Sebastian, given the context of Dolphin and the limitations of that?
So I think that study should be run in Southern Europe, where we have high MIC values, very resistant strains. So there, it really makes a difference if you optimize or not. Secondly, patients with rather high renal function, for example, that eliminate the drugs faster. And then certainly in a setup where you can really measure quickly, have a short turnaround time, and adjust as early as possible. So I think that has been discussed before. It is a subgroup that will benefit, and we have to find this subgroup and do the RCT in this subgroup. And that's probably the main challenge, to set this up in that way.
And with the a priori approach, it's very limited if you're going to be having consenting issues to get these patients on board. So it's like almost a consent to continue is what you probably would need in that circumstance as well, because I think with the Dolphin study, they actually consented or waited for consent before they could actually initiate. So I think that's one piece that I took back as well in my name. Yeah. Yeah. Paul, any comments from you before we get off?
I think Sebastian has described that quite well. And as you've mentioned about the consent, early consent or consent to continue, and perhaps the not combining the antibiotics and having the individual, the outcome for the individual antibiotic. No, nothing further to add.
On that note, I might thank all our speakers doing such a fantastic job and also staying till the end to answer some of these questions and have a bit of a discussion. We're finishing bang on at 7:45, so it's been a perfect webinar for everybody concerned. And I just really sincerely thank Tony, Sebastian, Paul, and Amy for fantastic presentations and sticking around and answering some questions. Thank you all, and have a great night. Have a great morning, Sebastian.
Thank you very much. Bye-bye.